what you found helpful, what you've not found helpful, and if the data is supported in your clinical practice or not. And I'll be very curious to hear what different folks do. And I will say that our nurses that take care of our pregnant moms on labor and delivery and our midwives are hugely expert in this area. And I'm very, very hopeful that we can get some input from everybody on this topic. So please chime in, particularly after we finish, so that we can have some discussion. Next slide. So induction of labor has been around for a long time. The goal is obviously to get a vaginal delivery out of the pregnancy by inducing contractions before the patient actually goes into labor. The question is when, and this has been a huge push, that we've learned. We used to deliver patients 37, 38 weeks. Oh, we induce them at 38 weeks, and we created more problems for moms and babies. So we know that we really shouldn't electively deliver someone before 39 weeks. If there's medical indications, obviously before 39 weeks is reasonable. So what are the risks? Why don't we just induce everybody? Well, there is a real risk of failed induction and cesarean section. The other risks are a little bit less common. Uterine rupture is certainly, if you're starting with an unfavorable cervix, the prolonged labor and risk of infection is higher, as well as postpartum hemorrhage and endometritis. But those are, so we'll talk about some studies that even question the cesarean section risk later at the end of the talk. Next slide. So we can't really talk about induction of labor without talking about cervical ripening. And ripening is literally, we're just trying to take a cervix that's not naturally ready for labor, and we do things to it to try to make it ready for labor. So we're trying to facilitate the natural process of softening, thinning, and some dilation, so that we can reduce our induction to delivery time. Now, that natural process takes days to weeks, we think, and it has to do with the breakdown of that collagen, that strong strength tissue of the cervix, so that we're trying to fit all of that process into a very minute period of time when we're ripening the cervix. Next slide. So the Bishop score is what many people use to determine favorability of the cervix for induction or not. A score of 6 or less is considered unfavorable. A score of over 8 is associated with a similar outcome, vaginal delivery success rate, as you see with spontaneous labor. So when it's not favorable, that's when we move toward cervical ripening. The next slide is just a table of the Bishop score. And I think we all use the Bishop score either officially or unofficially. I know our residents will assign a score, which gives a point or 2 or 3 points for each of these areas. Most of us who've been doing it as long as I have, just kind of in your mind, if the cervix is favorable or not when you check the patient and you're doing an unofficial Bishop score. Next slide. I'm not a huge component or proponent that you have to put a Bishop score in the chart. The different ripening methods, there are the osmotic dilators, the laminaria, there are the synthetic laminaria or the hygroscopic dilators, the Foley balloon and variants of that. And then medically, we use the prostaglandins and oxytocin to induce labor. The Foley balloon has been used to help develop a better device, I think, to help ripen the cervix, and it's a Cook balloon system, and there's a few other brands as well. The nice thing about these systems, they're relatively inexpensive. they're very effective at softening and dilating the cervix. They don't do a very good job at thinning the cervix, which takes a little bit of time once you start the oxytocin and get the contractions going. You can use oxytocin simultaneously with the balloon, and we do that some. We also can use the prostaglandins in association with the balloon. We do that some as well. And there doesn't really seem to be an increased risk of too many uterine contractions or tachysystole with the use of the balloon system. It works very well. Next slide. This is just a picture of the Cook system, which is a double balloon. And you can see each port is labeled. The S has a little metal stylet like we use with CVS catheters that literally can give the catheter form and help you get it through that cervix. The V is for the vaginal balloon. The U is for the uterine balloon. And you place the catheter, next slide, you place the balloon rather through the cervix into the uterine cavity, and then inflate the uterine balloon with 20 or so cc's of saline. Then you pull that back to assure that you're inside the cervix, and then you inflate the vaginal balloon. Now, a problem with using this is they have to have some dilatation, or at least a soft cervix, for you to be able to get the catheter in. If they have a very tightly closed cervix, this may not be your best choice. Next slide. Misoprostol is PGE1. It really has been approved through the FDA to treat gastric ulcers. It does work to lead to uterine activity. It is very effective at softening, thinning, and leading to cervical dilatation. The best thing for us, besides its effectiveness, it's very inexpensive. It comes in 100 or 200 microgram pills, and the pharmacy splits those into 25 microgram doses. You administer that every 3 to 6 hours. And curiously, it's equally effective orally and vaginally. It also can be given sublingually. I think here at Prisma in the upstate, I think they primarily use it orally. Eric, you can clarify that later. We have classically used it vaginally, and in my prior job in Kentucky, we used it vaginally almost exclusively, although we're switching a little bit now. The side effects are uterine tachysystole, with or without fetal heart rate changes. If you do have fetal heart rate changes, the usual things you do, the IV fluids, position changes, and sometimes you may even need to give some subcutaneous terbutaline to slow those contractions. The two administrative routes of this are different with the incidence of tachysystole. When you give it orally, there are fewer episodes of tachysystole, so that may be a benefit to using it orally. The downside is it seems to be a little bit longer induction to delivery time with the oral administration, at least from most of the literature. The prostaglandins in general across the board, misoprostol and dinoprost, will be contraindicated with previous uterine scars. So the increased risk of uterine rupture is significant. Next slide. So dinoprostol PGE2 is a gel form. It's either intracervical or in a little depot tape attached to a string that you put adjacent to the cervix. Equally effective to misoprostol, but much more expensive. And as a matter of fact, most hospital systems, including ours, who look at the data and look at the expense, will take the Dynaprost off of the formulary because it's hard to justify the cost difference. It does have a lower risk of tachysystole, and if it occurs, you can remove the insert. Again, contraindicated with prior uterine scars. Next slide. So oxytocin is the mainstay of induction of labor. It's given intravenously. The initial response time is 3 to 5 minutes, reaches a steady state in 40 minutes. There are low dose and high dose protocols depending on how you were trained and what your institution does. The Irish protocol, the active management of labor, actually would start at 6 millunits and go up by 6 every 15 minutes. In Kentucky, we did a hybrid of that. We did 4 and increased by 4 every 15 minutes. So when I came to South Carolina and saw that we were doing 1 unit increasing every 30 minutes by 1 unit, I was shocked. I had never seen that done. So, but that's basically what most institutions, I think, in the United States do. It is much more responsive if you have advancing gestational age. So really that effectiveness reaches a plateau at 32 weeks and continues to term. Before 32 weeks, patients do respond, but many times it takes higher doses. It's most effective with a favorable cervix, and our goal is to get contractions every 2 to 3 minutes. Just to review, tachysystole is more than 5 contractions every 10 minutes, averaged over 30 minutes. Next slide. So other methods that are considered induction of labor methods, and I consider this an augmentation, that is stripping of the membranes. It's something that we learned in residency. I think midwives have used this for years and years, and it has been shown to increase the number and proportion of patients that go into labor within 48 hours of doing the procedure. They have to be dilated for you to do this. You insert your examination finger and literally sweep at 360 degrees to separate the amniotic membrane, chorioamniotic membrane, from the surface of the cervix. And what we believe that does, and it has been shown in studies of serum levels of prostaglandins, it leads to a release of prostaglandins and relaxin and leads to uterine activity. Next slide. Other methods, amniotomy is breaking the membranes. I don't think that that is a good way to induce labor. I think it is a great adjunct to getting patients to labor when you're in the induction process, but I don't think that it's a good thing to start with. Nipple stimulation, I've never used. I know that many people do that as outpatients, and I know some of our midwives have done that, but I've not done that personally. All of these methods, membrane sweeping and nipple stimulation, really should be reserved for those patients that are over 39 weeks gestational age. Next slide. So the last couple of slides are just to talk about the attention that has been given to elective induction at 39 weeks. And this was the first really nice large study that was done, published in 2018. Over 6,000 patients were randomized. They were all prima gravidas at 41 different facilities. That's the downside of the study, the number of facilities. 39-week induction versus expectant management. And I gotta say, the results kind of surprised me. I'm not surprised that there's no difference in perinatal morbidity or mortality, but I was surprised that the C-section rate was lower in the induction group compared to the expectant management. The secondary outcomes were that gestational hypertension and preeclampsia was lower in the induction group, to me that makes sense. You're getting them delivered before they develop preeclampsia. And there was also a lower need for neonatal support. No difference across ethnic and racial groups. They were very equally paired in both of the arms of the study. Next slide. So personally, I think the take-home message is not that everybody needs to be induced at 39 weeks, although I'm a maternal fetal medicine doc, right? So I don't feel good until baby's in the bassinet. I mean, I want babies out as early as I can get them out safely. However, I do think that we fiddle around with nature sometimes more than we should. And I think that it is perfectly reasonable to induce a patient at 39 weeks if they would like to, if that's their preference. I think it depends on where you are. What are your resources? What's your staffing like? Some places I know in our own system struggle with having enough nurses to handle all the scheduled cases. So is it better to have the patient wait or not? It's not good to bring a patient in to induce them and they're in triage all night, right? Allow for longer latent phases is going to be key if you choose to induce people at 39 weeks with unfavorable cervix. And you need to give them at least 24 hours or you will see your C-section rate go up. And have the patient very well aware that the start of the ripening phase to delivery is longer if you electively induce at 39 weeks. And use oxytocin for at least 18 hours after rupture membranes before calling it a failed induction. And the last was just a recent publication that was brought to our attention here. I don't always read the JAMA. I try to when I can, but Dr. Gregg shared this with us where there were over 24,000 non-medically inductions of labor. And they looked at 3 different hospital sizes, which I thought was interesting. Hospitals that did less than 1,200 deliveries a year, 1,200 to 2,500, and then over 2,500, and showed that there were lower C-section rates with the induced patients in medium and large hospital delivery services, but really no difference in the small hospitals. I'm not sure exactly what that means, except I think the larger hospitals probably have more bells and whistles and people around and give patients longer. That would be my suspicion. Choreo and postpartum hemorrhage was lower in the induction group, and neonatal outcomes were better in the induction group. So really mirrors the same that we saw with the ARRIVE trial. So it does give a little bit of a backup or credence to that previous study that many of us may have questioned. Lastly, just special considerations. How do you manage fetal demises, particularly in the mid-trimester, both with and without uterine scars, high-dose Pitocin versus high-dose misoprostol? And that can be, actually, our case has to do with one of these that I will pose a question to our group to get their input. But I will stop with that. We can stop the recording.